I'd like to talk to you about diabetes, heart disease, and navigating through the muddy waters when it comes to cardiovascular risk assessment. I'd like to begin by introducing you to some individuals. That's me in the center, and to the right is my engineering problem-solving colleague, Ivor Cummins. His handle is the Fat Emperor, if you know of him. And last year, he convinced us to fly out to Chicago to meet the gentleman on the left, and that's Dr. Joseph Kraft, who is now 96 years of age. He's a living legend, and he is a retired pathologist. So Dr. Kraft spent a career studying insulin metabolism, and he noted that there was a strong relationship between insulin and cardiovascular disease. And so much so was that relationship that he said that those with cardiovascular disease not identified with diabetes are simply undiagnosed. And I'd like to explain to you why I think he said this. So Dr. Kraft was the chief of pathology and nuclear medicine at St. Joseph Hospital in Chicago. And over his 35-year career, he devised a test known as the 5-hour insulin assay. And he performed this test in over 16,000 people. Now, Dr. Kraft also had personally done over 3,000 autopsies, and he collaborated with others looking for the root causes of chronic diseases. Now, Dr. Kraft was also well published in the literature, but it wasn't until he retired that he wrote a book called Diabetes, Epidemic, and You. And I wish that every healthcare professional would read this book. And the book really details his career. It talks about the insulin assay and how it relates to cardiovascular disease. And I'd like to go into some of the detail now. So Dr. Kraft set out to show that standard methods of diagnosing diabetes and prediabetes were inferior. And by standard methods, we're talking about measuring blood sugar, either fasting blood sugar or after a 2-hour glucose challenge, or even a hemoglobin A1C. And the problem is that blood sugar or hyperglycemia, elevated blood sugar, is really a late finding. And what's important to note is that for type 1 diabetics, blood sugar, hemoglobin A1C is an excellent method to track progress. What we're talking about is using it as a screening tool, and that is where there's a problem. So the 5-hour Kraft insulin assay is based on the radioimmunoassay, which was developed in the late 1950s, and it was a method to measure small concentrations in the blood, in this case, measuring insulin in microunits. Now, at the time, people knew that type 2 diabetes, what they called back then adult onset diabetes, was a disease of insulin excess, but nobody had quantitated it, and that's what Dr. Kraft set out to do, as well as create a gold standard. So he actually reported 14,000 subjects in his book. And the insulin assay is done similar to the glucose tolerance in that a glucose challenge is offered, either 75 grams or 100 grams of dextrose or glucose. But what you did is not only measure glucose, but you measured insulin over a 5-hour period of time and at intervals in between. And when Dr. Kraft analyzed the data, he saw that it clustered into 5 distinct patterns. So there was pattern 1 that he called normal, and then there was pattern 5 that he called low insulin, and in between were these 3 patterns that he referred to as hyperinsulinemia, and that's what we call it today, or diabetes in situ. And what Dr. Kraft had done was to create a new method to diagnose diabetes and prediabetes, and also to diagnose diabetes at yet its very earliest stage. And we'll look at these patterns briefly. So here's the pattern 1, the normal pattern, or eubinsulinemia. So fasting insulin doesn't go up over, say, 5 microunits. We could say 5 microunits might be a normal range. And it doesn't peak at any point above 60 microunits. And superimposed are these 3 patterns of hyperinsulinemia. And you can see that pattern 2 and 3 in the yellow and orange are similar in that fasting insulin is low. Pattern 4 in the red is different in that fasting insulin is rather high, and it peaks to extremely high levels, almost to 200 microunits. So he really demonstrated that diabetes is a disease of insulin excess, or what we refer to as beta cell hypertrophy in the pancreas, where insulin is produced. Now, from a clinical perspective, I'm not necessarily interested in the specific patterns of hyperinsulinemia, just to know that they all represent the same thing. And I had the opportunity to meet Catherine Crofts in Auckland as part of my journeys. And what she did, she actually had met Dr. Kraft and she got a hold of all his data. And she recompiled it and found a simple clinical method that we use in our office. And what she had discovered, and this was for her PhD thesis that she's completed, was that if you simply measure a 2-hour insulin, and if the 2-hour insulin is below 30, you would be okay. And if it's above 40, you would have a problem. And this is what we use in our office. So we have this pattern 5, which I call pesky pattern 5, because we have to think about this. So this is the low insulin response. And there's two obvious situations where you would have a low insulin. Number one, if you're a type 1 diabetic and you never produced insulin in the first place. And number two, if you're what we call a burnt out type 2 diabetic, where your pancreatic islet cells, your pancreatic beta cells are no longer producing insulin. But guess what? There's two other situations where you have low insulin. Number one is when you're fasting, and number two is when you're on a low-carb diet. Anybody doing low-carb diet? Okay. Now, what Dr. Kraft demonstrated back in 1975, if you actually carbohydrate loaded the people who were on low-carb diets for, say, a week or longer, that this low insulin, this insulin pattern 5, would revert to a normal pattern or something else. And today we refer to that as physiologic insulin resistance. And there's some opposition to this, specifically stating that this pattern 5 somehow represents a glucose deficiency in the diet, a carbohydrate deficiency in the diet, or it represents insulin deficiency. But the argument here is that this is simply a normal physiologic adaptation to being on a low-carb diet. So I wanted to understand from a clinical perspective how insulin is a better measurement than glucose, so we have to compare. Now this is where all the data geeks and the nerds will appreciate this slide, but for the others, your eyes are going to glaze over. This is the one bad slide. So I looked at Kraft's data, and I created what's called a confusion matrix. And the engineers refer to this as type 1 and type 2 errors. So get ready. Here's your confusion matrix. And if you can understand it, it really provides a lot of useful information. Again, it's comparing one method, hyperinsulinemia, that we're calling the gold standard, to hyperglycemia. And if you look on the right of the screen, the positive and negative predictive value tells the individual getting their test their likelihood of having a given disease, in this case hyperinsulinemia, based on hyperglycemia. And on the bottom of the screen you see sensitivity and specificity. And that tells the clinician or the researcher how valid or accurate the method is, in this case hyperglycemia. And so let's say your test result comes back hyperglycemia, you have a high blood glucose. Well, you actually know that you have a problem because the positive predictive value is 97%. And the specificity is 92%. Those are very high numbers. So if your result is hyperglycemia, you don't have to do the insulin assay because you already know there's a problem. But where we have difficulty is when your result comes back euglycemic, or normal glucose response. The problem is that the negative predictive value is only 28%, and the sensitivity is only 52%. To illustrate, I'd like to show you two pie charts, and hopefully I can simplify this ugly confusion matrix. So here we're looking at the negative predictive value. And despite all the individuals here being euglycemic, having a normal glucose response, 72% in the red actually failed the Kraft insulin assay. So that's not reassuring at all. That's the big problem. Does everyone see that? And here we're comparing hyperglycemia to euglycemia. This is the sensitivity. Well, it turns out that hyperglycemia can actually pick up 52% of the abnormals in the green. It's not the best, but it's not bad. But the problem is that it's missing 48% of the individuals that were euglycemic and yet failed the Kraft insulin assay. So this is actually an argument to do more glucose tolerance tests and glucose challenges in the office. I've been doing it for over 16 years, but it's not popular. It's a pain for the healthcare professionals. But it provides a lot of useful information that's actually better than just doing fasting blood work. So at the end, I'll discuss how you can improve upon the standard glucose tolerance tests, both with and without insulin. But the bottom line here is that hyperglycemia or a high glucose is a late finding. And if you don't check insulin, you're not going to know that there's a problem, right? So the next question, can the Kraft insulin assay predict population risk? Well, let's take a look. So this study last year estimated that currently up to 52% of the US population are pre-diabetic and diabetic. That's a huge number. And I think Australia isn't that far behind, if they aren't already. And that number's about right. They actually did the standard method measuring of glucose properly. But imagine if they did insulin, because they didn't measure insulin. If they did, however, you could estimate that up to 2/3 of the population would fail the Kraft insulin assay. So the point here is that we're dealing with a huge problem, and we're not measuring it properly. This is the way to measure it. So I'd like to shift gears and talk about cardiovascular risk and ask a question, is there a diabetes paradox? So some people say that despite there being more diabetes and obesity, there's actually less heart disease. What? Well, we have to think about that. I think it's true since 1995 that we've done a much better job treating the complications of cardiovascular disease thanks to modern medicine, specifically the emergency medical system and modern day procedures and the intensive care unit. But that's really addressing morbidity and mortality. What we're really trying to ask is, what is the incidence, what is the prevalence, what is the occurrence of new disease? And that's a tougher question. So we have to consider that over the decades we're smoking less, we're reducing the consumption of trans fats, but at the same time there's more diabetes and there's more obesity. So I think we can answer this question by looking at subclinical disease. And what we mean by that is disease before a major event, before you have the heart attack, before you have the stroke. So how you do that is using tools that image the cardiovascular system. And the tool that we particularly like is the heart scan or the calcium score. And we'll talk about that later, but when you look at those studies, you see that with more diabetes and more obesity, there is more heart disease. And that's the whole point of our presentation. And we don't see that there is a diabetes paradox. So what did Dr. Kraft have to say about cardiovascular disease? Well, he said that atherosclerosis is a metabolic disease, and the defect is insulin. And if you don't address prediabetes and diabetes, you're going to be missing cardiovascular disease as well. And then in 1988, Dr. Jerry Raven makes headlines for his work on the metabolic syndrome that we more appropriately call the insulin resistance syndrome. And he too noted that atherosclerosis was a metabolic disease. And he broke it into components, including glucose intolerance, hyperinsulinemia, just like Dr. Kraft, and most importantly, what we call atherogenic dyslipidemia, where we're no longer looking at the quantity of cholesterol, we're looking at the quality. And you measure the cholesterol quality by looking at the ratios of triglyceride to HDL. You're looking at the particle size. And nowhere in this metabolic syndrome are we talking about bad cholesterol, such as total cholesterol, such as LDL. Also, elevated blood pressure is in there, and abdominal obesity. And not only was this associated with atherosclerosis, it was associated with all the other chronic diseases that we treat in modern medicine today. And when I first learned about the metabolic syndrome back in the late 1990s, I think this made a lot of sense. It really defined a root cause to explain chronic disease. But yet I was frustrated because although most doctors knew about the metabolic syndrome, they didn't know what to do about it. They were looking for medications. Now, metformin might help it a little bit, but as I see this, this is a nutritional syndrome, and it's treated with a low-carb diet. And you can imagine how unpopular it would be to promote low-carb diets at the time, and it's even difficult today. And Dr. Raven and Dr. Kraft, they weren't going to touch that giant elephant in the room either. So they just wanted to focus on their methodology, but I think they missed a golden opportunity to change nutrition. But you know what? Now it's our turn, right? So it's well established in the literature that there's a strong link between diabetes and cardiovascular disease. But when it comes to clinical medicine, not so fast. And I see this all the time. On the one side, we have diabetics that don't know that they have heart disease. And the other side, we have heart patients that don't know that they're diabetic. And even worse, their doctors are clueless. So why is there such a disconnect? Well, welcome to the Framingham distraction. That's Framingham, Massachusetts, where back in the late 1940s, they followed the population for decades to see which one had heart attacks and which ones didn't. And they saw that there were things negatively associated with this, and they called them risk factors. And we know them today, such as bad cholesterol, smoking, high blood pressure, diabetes. And since the original work, they've come up with different guidelines, different tools, different risk calculators, all based on a central theme: to lower the bad cholesterol. And therein lies the problem. And we're all familiar with this. You go to your doctor's office, he checks your cholesterol, your lipoproteins, and he generally gives you advice to lower the bad cholesterol, either with a low-fat, low-calorie diet and or medication. This approach doesn't address metabolic disease. It doesn't address hormonal dysregulation. It doesn't properly measure diabetes. This approach misses the mark. So here's your Framingham risk score. You ask a couple of these questions, and you take a guess whether you're going to live or die. It's a statistical guess based on epidemiology, and it's very difficult to apply any of this to the individual. Again, as I said, it's heavily cholesterol weighted. Now, some argue, well, we are measuring metabolic disease because diabetes is in there. Not so fast. Again, the calculators emphasize cholesterol. As I see it, diabetes risk is buried, and they don't measure glucose properly, and they don't even measure insulin. These are truly the muddy waters. So what's so important about lowering cholesterol anyway? Medical doctrine tells us that high cholesterol is bad and requires remedy, as if to say that cholesterol is innately toxic. Well, what are the mechanisms to support this? Well, for decades, they talk about some concentration gradient between cholesterol in the blood and cholesterol in the blood vessel wall. In recent years, they said, well, no, now I think it's inflammation that is involved. But overall, these mechanisms remain elusive. So what about studies to support this? Well, the diet heart hypothesis tells us to reduce saturated fat in the diet. But overall, that's been mostly unproven. What about medication? Well, you can tell patients who are free of heart disease to take a statin, but when you look at the benefit, it's actually very, very tiny. So we tend to not offer that to our patients anymore. It's important to recognize, however, that for secondary prevention, giving patients statins for mortality benefit is something to consider. And when we talk about secondary prevention, we're talking about individuals that already have had a cardiovascular event. So you need to consider that. But overall, we're not impressed. We can further debunk the lipid hypothesis by looking at some other studies. And these are just two, but there's many more. Although there are associational studies, you can challenge another hypothesis, in this case, the null hypothesis of the lipid hypothesis. So in 2009, they looked at almost 140,000 people who were hospitalized with acute cardiac events. And then they looked at their cholesterol. And what they found is that 3/4 of the patients actually were at Framingham cholesterol goal. What? So the question is, if they were at goal, what were they doing in the hospital having heart attacks? So this other study in 2015 looked at large populations of elderly people. And they looked at their cholesterol, and what they found is that the individuals that had higher cholesterol actually live longer. Go figure. So let's compare all that to the mechanisms for metabolic disease and hormonal dysregulation. And Ivor Cummins and I refer to this as the root cause diagram. And it's very similar to metabolic syndrome. So we see the liver's involved, the fat cells are involved, the blood is involved, and we have atherogenic dyslipidemia. And overall, we like to refer to this as metabolic mayhem. And downstream, it leads to things such as inflammation, oxidative stress, and advanced glycation that's ultimately damaging to the blood vessel wall. And as a result, we see atherosclerosis. Now understand that atherosclerosis is really the body's attempt to repair the damage. And this reminds me of the plumber. So your pipes are leaking, what do? You call the plumber, he comes to your house, he wraps some tape around the problem, but most importantly, you give him some money. Now I'm not referring to the cardiologist doing stents here, am I? But what did the plumber forget to do? He didn't check the water pressure. He didn't check the minerals in the water. He didn't address the root causes. And so you see it's the same with atherosclerosis. So what's the role of that bad cholesterol? Well, maybe it's not that cholesterol is innately toxic, but rather it's there as a consequence of everything else that's going on. And that makes sense. So what are the studies to support these mechanisms? Well, we want to compare diabetes and heart disease risk. We want to properly measure glucose and insulin and compare insulin to cholesterol. So we have a few studies to show you. So this is the Helsinki policeman's trial. It dates back to the 1970s, but what they did is they followed the group out over the years and then they measured their insulin. But what's good about this study is they properly measured insulin. They actually did a 2-hour insulin. And we can break the group down into low insulin and high insulin at 5 years. And here you can see that the low insulin group, the risk of having an event was only 1%. And then we go out 5 years and follow the high insulin group. Well, their increased risk is 9%. Now, to the untrained eye, you would think that that was small. But that's actually a 9-fold or a 9 times difference. It's almost an order of magnitude, which is a 10-fold difference. So this is actually a huge difference indeed. Now let's compare this to what generally happens to cholesterol over this period of time. So we have the low cholesterol group, and their risk is, say, 3%. And what do you think happens to the high cholesterol group? Does the risk go up? Does it stay the same? Does it drop? We have a drop. I hear drop. Well, the risk went up, only by 1%. So that's not even a 1.5 times difference. Now, if you compare 1.5 times to 9 times, that's a huge difference. That's like the elephant versus the mouse. So the elephant represents insulin, and the mouse represents bad cholesterol. Insulin will predict cardiovascular risk better every single time. So here's some more studies. They're called case control studies. And they more properly measured insulin and glucose and then compared them to cholesterol. And in most of them, you can see that insulin and glucose were significantly correlated with cardiovascular risk, whereas the bad cholesterol wasn't. In fact, 3 of the studies showed there was an inverse relationship, meaning that as cholesterol went down, the risk went up. But the authors have to be very careful to present data like this for fear that they're going to upset the medical orthodoxy. It's sad but true. So future research, we'd like to, again, compare insulin to bad cholesterol. We'd love to see interventional food trials looking at low-carb versus low-fat diets, but as you know, food trials are very difficult to do, very expensive. We'd like to track subclinical disease, looking at cardiovascular imaging as a research tool. There should be more of that. And we want to look at the hard endpoints, the hard cardiovascular outcomes such as heart attack and stroke. But until that time, the bottom line is, it's the insulin, stupid. I'm not talking to you, I'm talking to my doctor colleague friends there. And to recognize that atherosclerosis is a symptom of diabetes. And you therefore focus on metabolic disease, hormonal dysregulation, and insulin. And if you don't focus in your approach in this way, you're going to miss many. And again, it's not a medication approach, it's a diet and lifestyle approach because it is a nutritional syndrome. So the question is, what are the diet and lifestyle recommendations that we're going to give our patients to prevent those arteries from getting clogged? So I think metabolic disease should guide us. And so what drives hormonal dysregulation? What drives insulin? So carbohydrates become the first culprit, and then protein, and then in this context, natural fats, saturated fats become metabolically neutral. Now, as I said earlier, at least 2/3 of the population are afflicted with this. So this advice should be for most people. And this is the advice that we give to our patients, that low carb is best. We cut out sugar, starch, and grains. Fiber is okay. We eliminate processed foods, especially the highly atherogenic industrial vegetable oils. Leah had mentioned that also. That includes canola, corn, and soy. And we replace it with monounsaturated and saturated fat. If this is working well, we're going to be eating less. And I think that the low-carb message should really include eating less, but as a consequence of doing the right things. And there's so many other tweaks that we can talk about, but we have to be respectful of time. So clinical assessment, I wish that every healthcare professional would read Dr. Kraft's book. I wish that every healthcare professional could read Catherine Croft's PhD thesis. And to understand that fasting blood sugar is not a good method. Again, hyperglycemia is a late finding. We've done over 2,000 glucose tolerance tests in our office, and I told you, I think it's a valuable tool by itself. We've improved the sensitivity of the test by including a 1-hour glucose. Then, of course, you can measure insulin. Now, one thing that's important is that glucose challenging is probably not a test to do if you're already on a low-carb diet. I mean, if you're doing everything right, why should we tell you to eat 150 grams of carbs a day for a week prior to the test? So this is really an appropriate test for the general population. So you can measure a 5-hour, the insulin. You can do a fasting insulin less than 5 microunits. You might be okay. And then we do the Catherine Croft's method where a 2-hour insulin less than 30, you're okay. Over 40, you have a problem. And then we can measure inflammatory markers. And then we look at the cholesterol quality, looking at ratios and so forth. So we still measure lipoproteins. And then you can do body fat, waist to height ratio. So just to remind you that we're simply talking about eating real food. In this case, this is real Australian food. So we're going to finish by talking about cardiovascular imaging. And so we're looking for a test method that's inexpensive and non-invasive. And there's many methods here, and we choose the one at the bottom, the coronary artery calcium score. Now again, I said we're measuring subclinical disease before you have a major event. And the other thing is important to recognize that when you do the heart scans, it's providing historical data. We can compare that to measuring insulin, which tells you more about current metabolic health. So I'm trying to tie the two methods here together. So we have to thank the founding fathers, and they date back over the decades, who developed this technology. You actually might recognize the gentleman on the bottom left. That's Arthur Agustin, and he's famous for the South Beach diet. Well, guess what? He also helped to develop the calcium scans. I think he was way ahead of his time. But we really have to give thanks to all these gentlemen. So this is the calcium scan. So it's a CT scan of the heart where you're literally seeing the disease. So we have images of two different individuals. So how the calcium scan works is it's a high-speed CAT scan that takes an image of the heart and slices. It sees the calcium in the small coronary arteries, and then it adds it up, and you get a score. Now, as atherosclerosis develops, first it's soft plaque, and then as it hardens, you can see the calcium and measure it. So the individual on the right, unfortunately I don't have history, but you can see that the left anterior descending artery is bright right, is lit up. That's a high calcium score of about 1,000. Now David Bobbitt from Ireland, there's an Ivor Cummins connection there, produced a movie called The Widowmaker movie, and it talks all about the power of the calcium scan, and I would highly recommend that everyone watch that. In fact, David Bobbitt is funding an effort to produce a book that Ivor Cummins and I are writing. We have 4 versions of it already, so stay tuned. So here you can say that this individual has a very high calcium score of 1,000. Now the individual on the left, we do have some history. So that person is 54 years of age and has been on a low-carb, high-fat diet for over 15 years. And initially, he lost 18 kilos, and he's maintained this healthy lifestyle. And you can see in the left anterior descending artery, there's no calcium. And that's true throughout the entire sequence. Now, what's important is that individual happens to be me. And there's some chuckles, because people knew the punchline. So I have a perfect calcium score of 0. So my risk of having a major cardiovascular event in the next 10 years is less than 2%. I even have a 15-year warranty that I'm not going to drop dead of a heart attack right here. Now, let's hope that that all holds true. So, am I genetically blessed? Well, there's diabetes and heart disease in my family. I do have some favorable genetic markers, but I'd like to think that it's everything that I'm doing properly in my diet, with my diet and lifestyle, that I have this 0 calcium score, and hope that it remains so and that I continue to do all the healthy things I've been doing now for 16 years. So, what about the studies to support this methodology? And I can tell you that they're quantifiable and they're reproducible. And here's just a smattering of them. And you can see that as your calcium score goes from 0 to the 1,000 range, that your risk increases by an order of magnitude. And don't trust me, trust the studies. It's been done in literally hundreds of thousands of individuals. Now, although we refer to calcium as a risk, it really isn't a risk factor. Calcium sees the disease process itself. It is the disease process. Calcium is atherosclerosis, and atherosclerosis is calcium. And this summarizes the scoring. And you can see with a score of 0, your risk is less than 2%, versus with a score over 1,000, your risk is over 37, goes up 37 times. That's engineering precision. So as you can imagine, the calcium score blows away Framingham. And this is just a quick comparison. So here we're looking at individuals that have a Framingham risk of 10%. They put them into this one bucket. These are the middle risk individuals, where most people lie. Well, are they all 10%? Well, let's look at the calcium scan and see the truth. Well, they're not. So you can see that some of them are okay. They actually have a 0 calcium score. Some have the true intermediate risk, and some are at high risk. And so there's a difference again. All these individuals from a 0 score, perfect score, where the risk is low, versus a score over 600, where the risk goes up 36 times. So you can see again, Framingham takes a guess. Here the calcium scan sees the disease process itself. Again, it's digital. What if you're not so lucky and you have a high calcium score from the get-go? Are you doomed? Well, it depends. And this is where calcium progression becomes important. And the goal is to stabilize calcium. And let me illustrate. So here we're looking at real data, individuals that started out with a high calcium score, actually 1,000. And then you follow them out for 3.5 years. But the problem is their calcium progressed at greater than 15% a year. Well, look at their risk. They have a 50-50 chance of having a major cardiovascular event. So that's a problem. But let's look at the other individuals that actually, again, started out with a high calcium score of 1,000. But they stabilized their calcium, and we define that as progression less than 15% a year. Look at their risk, 3%. That's almost equivalent to having a 0 calcium score. So you can see it's very important to stabilize calcium. Now, you can do a calcium scan every 2 to 3 years. You have to consider the radiation. It's a very small amount. You could do it even sooner for people at high risk. But we're going to address this with all the root cause and the actionable items, diet, lifestyle, and with a very high calcium score, I think that it is reasonable to consider medications such as a statin. We all must treat them as a cardiovascular risk equivalent. So just some final points on the calcium score. It's in the 2013 guidelines across the world, and yet healthcare professionals don't know anything about it. I think the primary care doctor should use this as a proper screening tool because, as we do, we motivate patients to take positive action, positive change. And there's data to actually support this. I don't think the testing will lead to unnecessary more testing. Again, it's expensive and it's relatively non-invasive, just a small amount of radiation. And it's true that soft plaque isn't detected, but it really doesn't matter. It's the mathematics that predict the risk. Screening in general, 45 years of age or older. For women, maybe a little bit older. And you can even do it in younger individuals that are at great risk. And the goal, again, practically speaking, and what the data suggests is that you want to stabilize your calcium. People have reported that calcium reduces. I have 2 patients where the calcium went down, but again, the goal is to stabilize calcium. And lastly, the calcium score is obligatory for all US presidents and astronauts. So why isn't it available to the rest of us? So I hope that the muddy waters are clearing when it comes to cardiovascular risk assessment. We just talked about the calcium score. We talked about addressing metabolic disease. So when you and your doctor are grabbing for that Framingham risk calculator, it's best to think about metabolic disease, hormonal dysregulation, and insulin, because what's most important is to recognize that diabetes is a vascular disease. Thanks for your time.